Good morning. Hi, I'm Ed Manno. I'm going to be talking about neurological manifestations of COVID-19 or the SARS-CoV-2 virus. All right, so I think what we can talk about is what have we seen so far neurologically with this disease? What information do we have comes primarily from retrospective observational studies, case reports that we have, and this finding that these patients, the severe patients, have this very severe agitated delirium. Whether that is secondary to COVID-2 or is that just a process that we are seeing with severe viral pneumonias is unclear. I was talking to Rich Wonderlink about this today or the other day, and many of these patients in the past that had just SARS virus had similar type of presentation. The question is, we don't understand what this is doing neurologically. There are proposed mechanisms of neural invasion and secondary complications that we'll talk about briefly. Obviously, we need prospective studies and analysis and autopsies evaluations in these patients. This is what we have so far in terms of retrospective analysis, and as mentioned previously, it holds all the biases of retrospective analysis. These are patients that were just noted to have COVID that had some type of neurological abnormality. The one that is most quoted is this that was in JAMA Neurology, came out of Wuhan. Now, these were patients that had that were treated at an outside hospital and then sent to the 3 COVID hospitals that were in Wuhan, China. Of these 214 hospitalized patients, they grouped these neurological manifestations very, very broadly into CNS, PNS, and skeletal muscle injury. And they also grouped them according to the American Thoracic Society guidelines of having either severe infection or non-severe infection. When they looked at the neurological manifestations, overall, roughly about a third of these patients had CNS manifestations, much more commonly in the patients with severe illness. And primarily what they saw is they saw acute cerebrovascular events, and we'll talk about that a little bit later, impaired consciousness, and muscle injury with severe elevated CKs in these patients. And if you look at, I don't have an arrow here, but if you look on the graph on the right here, these patients appeared to have lower lymphocyte and platelet levels, but really not at a level that you would anticipate would be particularly problematic. As mentioned, we have seen this very, very severe agitated delirium. Eric Leota, Ayush Batra, and Rich Wonderlink have worked on a sedation protocol. I think as we in the neurology department were worried about this somebody said this consulting tsunami that was going to be coming because all of these patients are so severely agitated. Well, this was a letter to the editor that came out in the New England Journal last week. They had noticed this also. They did an observational study of 58 of consecutive hospitalized patients. The other ones had either died or had stayed on neuromuscular blockade. 7 patients had previous neurological history, and many of these patients, when you woke them up, were noted to have severe agitation, delirium, and neurological features. When they looked at that population, they saw that agitation was present in about 2/3 of these patients. If you did a CAM ICU on them, most of them were similarly also had confusion. But most interestingly, what you saw in these patients is they had diffuse corticospinal tracts, the reflexes were up, they had ankle clonus, bilateral extensor reflexes, so they had these long tract signs. When they did EEGs on these patients, it was relatively nonspecific, and the CSF was relatively bland, and they were unable to identify any PCR of the virus in the CSF. Most interestingly, of the patients that survived and were discharged, about a third of them had severe cognitive difficulties, resulting in disorientation, inattention, and inability to sort of follow complex commands. When they looked at the radiographic imaging in these patients, they saw in 13 of these patients had an MRI. 8 of them had leptomeningeal enhancement. Interestingly, we're seeing it mostly in the posterior fossa. We just got a patient yesterday, a transfer in from Canada, supposedly COVID negative, but is picking off cranial nerves, has an MRI that looks very similar to this. I am very suspicious that this patient is going to turn out to be COVID positive. Similarly, when they've done cerebral blood flow studies, in 11 of 13 of these patients, there's hypoperfusion in the frontal lobe that has been noted in these severely agitated patients. Again, the list of what we're seeing, we'll talk a little bit about the case reports. One of the things I've been concerned about is we've been waiting for this deluge of post-viral Guillain-Barré patients. We haven't seen it yet. There are 5 cases that are reported out of Italy thus far. 3 of them were demyelinating, 2 of them were axonal. Unfortunately, thus far, the ones that had the axonal forms have not done well. A couple of these case reports. This is the one that's got the most attention. This came out of Henry Ford, of this acute hemorrhagic necrotizing encephalopathy. As you can see, the MR features with it below is a viral meningitis that has been documented. One of the early features that was discovered is the fact that this appears to have olfactory and gustatory dysfunctions that are associated with it. This was a European cohort of 417. These are relatively mild patients, but as you can see from the numbers there, a significant percentage, almost all of them had some degree of olfactory and gustatory dysfunction. And the early recovery rate was only about a half of these patients. And I can tell you this is a really particularly disabling symptom. I had a friend of mine from New York call me. He went through the entire syndrome, thought he was getting better, and then at the very end lost his sense of smell and taste. And he said, you know, I'm in lockdown. The one thing I can do is cook and eat, and I can't even enjoy that with it. This is a letter to the editor that's looked at the prevalence and intensity of this altered sense of smell, and this was in JAMA. And they contacted 283 patients via telephone survey about a week after they had been infected. And they gave this sinonasal outcome test with the unfortunate acronym of the SNOT score. And subsequently, what that score goes from really being non-affected to 5 being you can't really smell or taste pretty much anything. And the majority of these patients leveled out somewhere around severe disorder of 4. And about 6% of these patients reported that it was their only symptom that they had of COVID. Interestingly, we originally thought this was the inciting symptomatology that people have, but more and more we're seeing it can happen anywhere along the course of the disease. So hypothetically, how can this virus get into the CNS? Well, the nasal mucosa has the highest density of ACE2 receptors in the bronchial tree. So obviously you can get this probably through the nose. Is there a direct hematogenous spread, either from infection of the endothelial cells that disrupt the blood-brain barrier, or is it a secondary process due to blood-brain barrier breakdown in the setting of this cytochrome storm? Can there be transsynaptic transmission? We don't know that as of yet, and some people have suggested lymphatic system could be involved with this. We do have evidence in a mouse model of other coronavirus. This is the coronavirus OC43, that it can propagate in mouse axons and transsynaptically infect other neurons. Similarly, what we've seen in transgenic mice for the ACE2 receptors, that if you inoculate these mice, and you can see an E and F here, that this is naive hypothalamus and brainstem, that there is viral antigen in the SARS-CoV mouse that you can see that these areas are infected. And in particular, if you look at the brainstem areas of these mice that are infected, it's infected in the area postremia, the dorsal modal nucleus. I won't go into great neuroanatomy detail, but suffice to say that these are areas that can have profound cardiorespiratory effects. There's also been documentation of the SARS-CoV-1 in humans in 8 patients where they have autopsies. They can see that there have been scattered neurons throughout the cerebrum and also in the brainstem. So can we have direct neural invasion into these respiratory centers? We don't know. Certainly, hypothetically, it could happen. It is very, very interesting. Many of these patients develop this almost type of neurogenic respiratory pattern. It's a relatively rare pattern, seen extraordinarily uncommonly. I've seen it only twice in my career with direct lymphomatous involvement in these centers and with the case of Irvine-Chester disease. But these are patients that will blow their PCO2s down into the single digits and start seizing. There are reports patients that will breathe at this level and have no sense of dyspnea. They don't have any sense that anything's wrong with them. And there is at least one report of a patient with complete loss of voluntary respiration with this. What about cerebral vascular disease? There is a noted hypercoagulable state. Dr. Zakaria, I will let speak to that. I will just tell you that I have heard of, and we are going to hear of this week, 5 COVID patients that they are presenting with large vessel occlusions that went to thrombectomy. The interesting part about this is they all were in their 30s and 40s and had absolutely no risk factors. So it may be that acute stroke is actually a presenting sign of COVID. Obviously, there's much needed work. Literally, as mentioned before, this is changing on a daily basis and something that we all need to keep up with. So I tried to stay on time, and I'll pass this over to Dr. Zakaria and take questions on the end.